I'm David H. Adamkin, Professor of Pediatrics at the University of Louisville, Director of Division of Neonatology, and I'm speaking on hypoglycemia, neonatal hypoglycemia, in particular looking at different opinions, those from the American Academy of Pediatrics and those from the Pediatric Endocrine Society that have been offered for management of low glucose levels. We begin by looking at glucose levels that are shown in red, maternal glucose concentrations, and then in blue are fetal glucose concentrations, and these are mean levels. The mean maternal levels are around 80 milligrams per deciliter, and in blue, the fetal concentrations are around 60 milligrams per deciliter. Superimposed on those two lines are actual confidence intervals, 95% confidence intervals of baby levels over the first week of life, with most of the levels shown over the first 48 hours of life. And you see a very wide range of glucose levels for the newborns. While the mean may be 60 milligrams per deciliter, you see that at the nadir, 1 to 2 hours of life, the levels may be as low as 25 milligrams per deciliter. You also see that looking at the mean levels for the babies, you actually see that over the first days of life, the mean levels rise and join more adult levels by the third or fourth day of life. So the first 48 hours of life is absolutely unique and called transitional hypoglycemia, which is actually a transitional hyperinsulinemia is responsible for this observation the first 48 hours of life. Now, in coming up with recommendations, the Pediatric Endocrine Society used mean levels to define the ranges or the levels that they recommended. The Academy of Pediatrics used what's called operational thresholds, which are ranges of glucose, which essentially take into account the lower ranges of glucose in asymptomatic patients as their guide, and also the clinical condition of the baby being most important. And at the end of the day, the levels were also developed utilizing data from neurodevelopmental outcome studies. So the main difference is Pediatric Endocrine Society mean levels, and mean levels at which it appeared that neurogenic responses occurred in adults below those levels. The AAP approach using the low range of glucose levels, and then basing clinical condition and data on neurodevelopmental outcome to come up with operational thresholds, ranges of glucose levels that a clinician could use to make decisions. Now, one study that led to 47 becoming the gold standard for the world was a nutrition study in the 80s. And in this study, they looked at daily glucose levels that were obtained as part of a nutrition study in babies less than 32 weeks gestation, babies with an average birth weight of around 13 to 1,500 grams. And what they found was that the more often these babies had glucose levels less than 47, that correlated with poor outcome at 18 months of age. It turns out when these babies were examined again at 7 or 8 years of age, that these deficits had essentially resolved, and the authors actually admitted that the method of sampling and using this to determine outcome related to glucose level really was not optimal, and that a prospective observational study would be the way to go. As an aside, it also turned out that a number of these babies had very modest glucose levels that were not treated for days, levels less than 20, because they were part of a nutrition study and the hypoglycemia was not directly addressed. So this study was repeated in the same country with different investigators in a prospective manner, where they looked at babies less than 32 weeks who had at least 3 days of life, the first 10, with a glucose less than 47, versus those who did not. And at 2 years of age, there was no difference in outcome for the babies who had glucoses less than 47 versus those who did not. What was fabulous about this study was that they followed these kids again as adolescents. at 15 to 16 years of age again, and there was 82% compliance in following up. And it turns out that full-scale IQ, whether it was reading, whether it was behavior, adaptation to daily living, or cerebral palsy, there was no difference between the babies who had levels less than 47 versus those with greater than 47. So for the American Academy of Pediatrics and Fetus and Newborn Committee, we felt like the developmental data was solid, that 47 was not a critical level for defining hypoglycemia. So shown on this slide is the algorithm from the Academy of Pediatrics for screening and management of postnatal glucose homeostasis. 4 risk groups: late preterms, all of those babies should be screened. Term SGAs, term IDMs, term LGAs should be screened. And the babies that are late preterm and SGA should be screened every 3 hours for the first 24 hours. IDMs and LGAs should be screened for 12 hours. Any baby that is symptomatic, and the symptoms are listed at the bottom of the slide, and have a screening bedside glucose less than 40 should be treated. And they should be treated as shown in the middle of the slide, with a target glucose greater than 45. The glucose can be given as a mini bolus and then followed with an IV infusion of 5 to 8 milligrams per kilogram per minute, 80 to 100 cc's per kilogram per day. So that would be for the symptomatic baby, bedside screen less than 40. The vast majority of babies that are going to be treated with this algorithm are asymptomatic, and it's divided into 2 periods. Birth to 4 hours of age, which is transition, and that's the period where the baby reaches the nadir of glucose level and then begins to rise, and then 4 to 24 hours of age, where the baby continues to have an increase in glucose level, as shown on the first slide. Initial feed should be within 1 hour. Screen the glucose 30 minutes after the first feed. If the initial screen is less than 25 and the baby remains asymptomatic, screen again. If the glucose is still less than 25, then the operational threshold for action is less than 25, the baby should receive IV glucose. If the glucose is between 25 and 40, that's an operational threshold. That's a decision made by the healthcare provider whether to simply feed that baby again or move on to intravenous glucose. That decision will be made by the healthcare provider based on the baby's exam, risk factors, and how the baby is doing. The second period, 4 to 24 hours, continue Q3 monitoring. Now the operational threshold for treatment is less than 35. The baby will receive IV fluids. Or 35 to 45 is the operational threshold, where the clinician decides whether to simply refeed or provide intravenous glucose. As I stated earlier, this algorithm is based on ranges of glucose in babies. It's based on the exam of the baby and neurodevelopmental data suggesting levels that appear to be safe. The operational thresholds then are those levels where we believe there's a flexible margin of safety. Thank you.